Good afternoon, everybody. My name is Sandra Saldana Ortega, and I'm a co-founder of Alva Health. And we are a team of experts with backgrounds in stroke neurology, electrical and computer engineering, and business. And we are on a journey to revolutionize access to stroke therapy by building a simple, wearable medical device that can be worn by patients with the highest risk of stroke. The genesis for this venture came about when our clinical co-founder, Dr. Kevin Sheth, was a fellow at Mass General Hospital up in Boston. And he found that oftentimes he would get a call from the emergency department, and the number one question was, can we give this patient TPA? And overwhelmingly, a majority of the time, the answer was no. Now, for those of you that are not familiar with stroke, ischemic stroke happens when there's a blood clot that blocks blood flow to the brain. And the only FDA-approved therapy for this disease is TPA. And unfortunately, it must be administered within a time window of 3 to 4.5 hours after the onset of symptoms in order to be effective. And so a majority of the patients arriving at the emergency department actually are too late. They're far out of that window. And so Dr. Sheth set out to come up with a solution to solve this problem. And today I'm going to share with you our solution, which is a wearable monitor that is powered by a powerful algorithm in a machine learning algorithm that can detect symptoms of stroke as they happen. And now the reason that this is such a big problem is that we really don't have any methods for detecting stroke in the everyday setting. In fact, only about 30% of the general population is aware of the symptoms of stroke, which include face drooping, arm weakness, and speech difficulty. And so this is a really big problem because because ischemic stroke affects over 800,000 patients every year in the US, which results in over $33 billion in cost to the healthcare system when these patients don't get treated. And so there's a saying in the field that time is brain. So out of this $33 billion in healthcare costs, we determined that about $2 to $4 billion is accounted for by what we call recurrent 90-day strokes. And so these are strokes that happen within the 90-day window after a patient is released after their initial event, either a stroke or a mini stroke. And we find that actually in this population, they are overwhelmingly more likely to be either Hispanic or Black. And so not only that, but these patients have worse outcomes overall, and they have a greater need for rehab. And even though they need more help, unfortunately, they're more likely to be sent home without any sort of monitoring. So there's really a very specific need that these patients have to have a solution like the one we're proposing here. And again, so the solution essentially is wearable sensors that are worn on the body, and they detect paralysis in half of the body. So this is linked to an iPhone application, which is powered by an algorithm that is housed in the cloud. And this machine learning algorithm essentially can tell when somebody is having a stroke in real time. And this is where we are today. On the left-hand side, you can see a mock-up of our prototype, which has enabled us to validate our algorithm and determine that we're actually able to differentiate normal versus stroke subjects. We're in the process of transitioning over into the second generation, which is going to be using off-the-shelf sensors and components. And in the next couple of 2 to 3 years, we are working with potential partners. We're in conversations with IBM to help us co-develop this device into a commercial-grade device that can be cleared by the FDA. And this is an example of the diffusion maps that we're able to capture with our algorithm. Now I know that this looks simple, but it's a two-dimensional representation of really an environment of each patient as they're moving about throughout their day. So this is just one of the metrics that we're measuring. And on the left-hand side, you see that the left arm and the right arm are quite symmetrical in a normal subject, but in a stroke patient, as you can see, there's a very dramatic difference when somebody suffers a neurological insult, and the left arm seems to be completely paralyzed, while the right arm, we still are able to capture some of that deficit. So the value proposition that we're looking at is really threefold. For patients, it's very clear. These patients they're debilitated. They're leaving the hospital with a stroke. they don't want to worry about a second stroke. They want to focus on recovering. And so we're going to be there to have their back. We're going to help them to watch their back and make sure that they can get to the hospital in the case of a secondary event. For providers, this tool will enable them to use the drugs and therapies that are at their disposal so that they can actually treat the patients within the time window that they have so they can help them. And for payers, there's a very significant cost savings that results when patients are able to get treatment. So we have shorter hospital stays, less time in the rehab setting, and then less need for long-term care. And so we're aware that there are a lot of players entering the healthcare wearables market, but a grand majority of them are actually entering the low-hanging fruit. So they're going after wellness or general fitness indications, and very few are actually going after medical indications, and even fewer are going into the cardiovascular space, and that's where we play a role. And I just want to point out that there are a couple players, but these guys are measuring EKG monitoring, which detects heart arrhythmias, which may someday turn into a stroke, but maybe not. So we are the only group that is actually tackling stroke head on as it happens in the real-time setting. So we did an analysis of existing cardiovascular monitoring devices, and we think that we can charge about $1,000 per device using off-the-shelf components. And we did an analysis of the unit economics, and we think that this field is actually rapidly turning into a commoditized market. So the suppliers in this space their prices are getting cheaper, and they're getting faster and better overall. And so we think we're going to have very favorable unit economics overall. And we found that the real value for our technology is actually in the algorithm and being able to detect stroke. And that's really what we're focusing on, creating that gold standard data set for stroke. And this is a snapshot of our projected revenues over the next few years. We'll have a product out on the market within 2 to 3 years. And we hope to leverage Dr. Schett's relationships and understandings of the local market and launch our product at Yale New Haven Hospital, and then move up and down the East Coast and eventually down to the stroke belt, which is the southeastern United States, which extends from Texas all the way to Florida, which is where our needy population, so those Hispanics and African Americans, that's where the highest concentration of stroke actually occurs. So some of our recent success, we have a non-provisional patent for our technology. We have a proof of concept study that has proven our powerful machine learning algorithm. This has resulted in some awards locally across campus, including the YEI Summer Fellowship this summer, which we're excited to be a part of. And not only that, but we've been able to generate external support and excitement and interest from potential partners, including IBM and Smart Monitor. So this is our team. My name is Sandra Saldana Ortega, and I am the CEO. Dr. Kevin Scheth is the Chief Medical Officer. He oversees over 3,000 stroke admissions at Yale New Haven Hospital every year. Dr. Hiten Zaveri is our CTO. He is an expert in electrical engineering who was developing our technology. Dr. Ron Koifman is our machine learning expert who has developed this powerful algorithm. And Dr. Susan Froschauer has been our business mentor throughout the process, and she played a key role in bringing our team together. And at this point, I'd like to open it up to some questions.
Good afternoon, everyone. Thank you for coming to listen to our pitch. We're Team Better Care. My name is Max. I'm a first-year medical student.
I'm Nick. I'm also a first-year medical student.
I'm Edward. I'm from the School of Management.
With Better Care, our goal is to hack implicit bias in healthcare. So I'll talk a little bit about how implicit bias works. This is an element of our brain that helps us process information and make decisions in sort of short amount of time. So if I'm crossing the street and I see a car driving really fast towards me, the first instinct is just jump back onto the sidewalk, and that's kind of how implicit bias works, and we all have it. Unfortunately, that also helps us make decisions about people we interact with. And within healthcare settings, physicians have been shown to act upon their biases against racial and ethnic minorities, LGBT people, obese patients, the elderly, differently able individuals, and women. Unfortunately, this leads to worsening health disparities. For example, studies have shown that African American patients are much less likely to get adequate pain treatment for all types of pain, or also they're much less likely to get, for example, rushed to the cath lab if they show signs of a heart attack in an acute setting. On top of that, the different barriers that such patients face outside of the healthcare system can compound on the effect of implicit bias. Imagine being, say, an elderly black woman struggling with food access and going into a clinical encounter. Potentially because of the bias, the physician is much less likely to confront the aspect of food insecurity in that setting. And that has an impact on the quality of care that this patient is going to get. So hence why those structural vulnerabilities, as we call them, end up having a sort of a negative interaction with their health disparities. Unfortunately, health systems have not yet found effective and innovative solutions to address the issue of implicit bias. So what we're proposing here will be a web app platform to teach physicians about implicit bias and structural vulnerabilities with clinical applications and key takeaways. Our platform would follow the framework that cognitive psychologists are recommending for hacking bias, meaning, one, the first piece is motivation that has to come from the user. Second, information, so educating the user about the psychology behind implicit bias and the clinical implications and impact that has on different patient populations. Next is the emotion aspect, which would be positive reinforcement and positive feedback as a user is going through the app, and ultimately orientation, which here come the key takeaways that we would provide the user. So what's new about this is that, one, we're providing our users with sort of a longitudinal and digital learning platform in ways that hasn't always been the case when it comes to implicit bias. And why is this important? Bias in our society tends to be something that's a little bit taboo to talk about in public settings. Usually in hospitals or in medical school, the way this is addressed is in group settings or in lectures where individuals may feel burdened by having to have such discussions. So we're offering users the opportunity to sort of confront these biases and their attitude in the face of bias in their downtime and sort of a private setting to not have to feel that burden. Additionally, we're aiming to address both implicit bias and structural vulnerabilities and how they interact with each other and ultimately have an impact on patients. And then the gamified aspect, where users will have the opportunity to apply the knowledge that they gain throughout the application on clinical scenarios to make it a more interactive experience and providing them with sort of key takeaways. Now, in terms of competition, there are a couple of companies there that exist that aim to address implicit bias, but they either talk simply about implicit bias or focus on a notion of cultural competence. Now, for example, Be More America focuses on hacking bias in healthcare, but most of these settings tend to be one-time interventions, and research has shown that one-time interventions don't have a lasting impact on physicians beyond 48 hours, and we see how that can be problematic, especially if these interventions are costly. Now, the issue of cultural competence has also been shown somewhat to reinforce some stereotypes within different groups because physicians are expected to sort of know all the different aspects of the different cultures that they may be taught on. Now, so now we're proposing with Better Care would be a digital and longitudinal experience that will implement both the idea of implicit bias and structural vulnerabilities. I'm going to pass it on to Nick.
Okay, great. So I'm going to talk for a little bit about our development process. In the next 3 months, we'll be consolidating the content that we plan to use with our program. So this is going to mean, academic literature, as well as compiling information in the local area about structural vulnerabilities that patients may face. And as well as we're going to be producing the application itself and testing it and producing a beta software to pilot, which will be the next 6 months. We're first going to start the pilot with residents and students. We're going to be looking mainly to see the usability, to optimize for the user's approach to the tool, as well as improvements that are seen in the individual's ability to act on the information that we present to them and actually produce better outcomes for their patients. After that, we'll pilot it at our first client site, which we are hoping to be Yale New Haven Hospitals. During this time, we'll continue to receive feedback and use this to improve upon the app, such as usability, as well as to use this to gauge the metrics that we're getting. So we'll be tracking the users and receiving information and using that to make the application more robust. And then in the next stage, the final stage, we'll be enrolling our first client. At this stage, we'll hope to be incorporating local information from, in this case, the New Haven area, from sources such as Data Haven, who produce community resources and kind of gauge what the population is like here. So part of that is really important, is individualizing this to a site-specific nature. Because like Max said, we don't want to use these innocuous kind of cultural competency measures to define a population. We want to look at what's actually happening and where you are. So this is kind of like a little bit of what the product's going to look like. If you can see on the left-hand side, this is like the home page where you'll be able to look at implicit bias, or go into the clinical scenarios and learn more about structural vulnerabilities. So the implicit association test is a tool that we'll be using to help the user become more self-aware of their own implicit biases. These are tests that have been shown to help elucidate that, and by having the user go through this process, they'll become more mindful of what they might bring to the table, and hopefully this will motivate them more to address these issues through the learning curriculum that we have in place. And to pair the implicit bias with the structural vulnerability component, those are really interconnected, and so by educating on both, we'll hope that the user actually improves. So in the last bit, we'll be testing this by having clinical cases that are a model that's used today in medical education, but we'll be targeting not towards the medical condition that the patient is presenting with, but more to kind of address how a physician might go about addressing structural vulnerability in these patients. Finally, the user will be able to monitor their progress through the app, their educational development, and this will be used as well by the health systems to kind of track their overall progress with the user interface. I'm going to hand it off to Ed, who's going to talk about our market.
Thank you, Nick.
Can you guys hear me in the back? All right. Okay, perfect. So there's about 5,500 hospital systems in the U.S. currently, and this accounts for over $3 trillion of our annual GDP. And this shouldn't come to a surprise to anyone. This is a huge market. The healthcare industry is a huge market, but what many people don't realize is that about 10% of that, about $309 billion, accounts for unnecessary costs due to healthcare disparities between various minority groups. And if we also acknowledge the fact that healthcare systems spend anywhere between $7,000 to $80,000 per employee per year for training purposes, this is a significant market to be had. And the average employee training is about $1,500 in the US. And so, leveraging this opportunity, we plan to price our product as a software as a service subscription based on the number of users and the length of the service. Our target clients are obviously going to be healthcare institutions, medical schools, and even insurance companies. So basically, any stakeholder that can gain from the cost savings from our product. And from a growth standpoint, as Nick mentioned before, we plan to pilot it in Yale New Haven in the fall. And then we expect to have about 15 hospitals by 2020 with 10,000 registered users and $3.6 million in revenue. And so this concludes our presentation. Thank you so much for the judges for giving us this opportunity, and we'd love to take any questions.
Good afternoon, everyone. We are Vici and Christina, and we are here to unveil Real Talk. So to begin, we'd like for you to experience our current prototype.
Cause I know I don't understand. Stop your looking, doing
And now we'd like for you to hear from some of the teens that we worked with in North Carolina and Texas who helped to design Real Talk.
Personally, it seems like a good place you can go to virtually to talk about your problems rather than saying them in person, because some people really don't have the confidence to, talk to your parents about this stuff. So this is a good place you can come to get advice. Like basically what's going on, this could happen to us like in our future lives. So this is a good place to go to get advice on what to do in certain situations.
Also, I had when we were working in the focus group for this app, I had came up with the idea of like the guys on one side of the screen and then it was split, and then females, and it was a purple line. And they actually took my idea into consideration, and they made it better because now you can actually see exactly who is in the person given. You can actually see how parents feel about certain situations.
This app, it has real stories, people going through the same thing, and I think it would be cool to see that I wasn't alone.
Real Talk is a mobile app that uses daily stories instead of traditional health messages to help middle school students learn about sexual health topics. All of our stories are written from multiple perspectives and are presented as text message conversations. We aim to build a delightful and engaging mobile app that will transform sex education through storytelling for middle school students all across the country. We plan to launch Real Talk in the next 12 months and engage 1,000 users. And our goal today is to secure the $25,000 competition prize in addition to your endorsement and support to turn the prototype that you just saw into a reality. Today, we'll walk you through Real Talk's innovation, our proof of market, competitive advantage, go-to-market strategy, and financials before opening it up to Q&A. Next, I'll talk about Real Talk's innovation, but first I want to focus on our team. Each of us have lived and worked for many years in rural and low-income communities that have limited access to sex education and high rates of teen pregnancy. We're deeply committed to finding an innovative solution that will help to address this problem. Our team has also shown that we can effectively apply our skills, secure resources, and execute quickly towards our vision of improving sex education. In the past 6 months, we've experienced rapid growth, going from a preliminary concept to building an impressive network of partners that currently include the U.S. Department of Health and Human Services, IDEO, and countless students and educators all across the country. We're the most capable and committed team to developing and evaluating a project of this scale. Now I'll focus on Real Talk's innovation. First, it's important to know that middle school students like learning from the experiences of others. So we approach sex education through storytelling. And even at these early stages, we've already seen students change what they think and what they do based on the stories that they've read in Real Talk. We're confident that our storytelling approach is superior to anything that currently exists in the sex ed world. Second, traditional sex ed is very gender binary and heteronormative. In contrast, Real Talk provides stories written from multiple gender perspectives and specifically includes stories from LGBTQ teens. Finally, our approach is distinct because we use real stories written by real teens. In a matter of weeks, we've collected over 100 stories from teens all over the country, and currently no other mobile app engages teen voices as effectively as we do. Our cutting-edge approach that uses stories, perspectives, and authentic teen voices will make sex education engaging and more effective for middle school students. Now I'll share with you how we've established proof of market for our product. We know our product is viable based on our extensive user-centered design research and testing. We've conducted 50 prototyping sessions with over 300 teens across Connecticut, North Carolina, and Texas to design the product that you've seen here today. We've built a fully functional web prototype that we actually will test next week using a week-long pilot in order to better understand multi-day engagement. And to test our concept in the wild, we've launched several Instagram ad campaigns where with just about $300, we've generated 1,000 likes on our ads, hundreds of comments, and over 350 user signups from teens that we've never met or even spoken to. We've designed our product to respond directly to student needs and desires, and based on these early successes, we're confident that we can stand out in this market.
Now I'm going to take you through the competitive landscape, our user-centered design process, go-to-market strategy, and financial plan. To showcase how we are filling an unmet need in the market, we've put together this matrix. Our competitors include sex ed websites, mobile apps, in-classroom sex ed, and TV shows. Our competitors do many things well, but the reality is that middle school students are not accessing them. When we asked teens how often they'd visited different sex ed websites, Only one of the 55 students we talked to had ever even heard of them. However, almost every teen we have ever worked with has their own smartphone and accesses mobile apps every day. By building a mobile app, we are meeting them where they already are. Our main mobile competitors include Juicebox and Vent. When we showed these apps to our students, they told us that they were uncensored, irrelevant, and negative. Real Talk carefully curates every story that ends up in our app, and we take a lot of precautions to make sure that we're maintaining their anonymity. We've differentiated ourselves by creating a safe and positive space for middle school students to engage with sex ed. Now I want to take you through our process. We know we've built a product that our users love, and that's because we have followed a rigorous user-centered design process. A year ago, we had the opportunity to receive training from IDEO, one of the world's leading design firms in human-centered design. We then followed their process all last summer to engage with hundreds of middle schoolers and test many, many prototypes before arriving at our current concept. We were then able to raise funding from the Office of Adolescent Health and this Innovate Health Yale Seed Stage grant. In the last 6 months, we built an amazing board, hired 3 team members, built a fully functional web prototype, and we'll be testing that next week. We've made tremendous progress and have proven that we can both attract and effectively deploy resources towards solving this problem. So let me tell you how we plan to bring Real Talk to market. Our goal by May 2018 is to launch a mobile app and have 1,000 engaged users. The $25,000 from this prize will be instrumental to helping us reach that goal. Like I said, over the next month, our intention is to pilot our mobile prototype with users across North Carolina and Connecticut. We hope to use the insights from those pilots to build a beta version of our app this summer. The $25,000 will fund a full outcome evaluation of that beta. That will help us ensure that we are having a positive impact on students' knowledge, attitudes, and behaviors before we decide to scale. So let me help take you through our plan for financial sustainability. Although we are a nonprofit, our goal is to be 50% funded by earned revenue by the year 2021. We've already had many conversations with potential customers to explore different possible revenue models. For example, the North Carolina Department of Education has already expressed interest in contracting with us to do design thinking training for their entire staff. Separately, Peer Health Exchange, which is a nationally renowned health education nonprofit, is interested in paying us to help them develop stories written by real teens that they can use in their lesson plans. Based on these early conversations, we're confident that we can find a way to diversify our revenue sources and eventually get to financial sustainability. We are committed to launching Real Talk and transforming sex education through storytelling for middle school students across the country. To reach that goal, we require the $25,000 from this competition. However, we also want you to open up your networks to us and help connect us to schools and nonprofits that can eventually spread the word to early adopters. We want you in our space for the next 12 months and beyond, working alongside us to help take Real Talk to its full potential. Thank you, and now we are happy to answer your questions.
Good afternoon, everybody. Thank you so much for inviting us to present. So it's a real pleasure to be able to tell you about Navigator, a mobile healthcare companion for the emergency room. As medical students, we have been incredibly privileged to be able to enter patients' lives in their greatest hour of need in the emergency room. And I'd like to start by telling you the story about one patient that I saw a few months ago, who I think his journey really shows the ways in which we hope that Navigator can help be a tool for improved patient engagement, education, and empower them along their path. So Mr. G was a 42-year-old, otherwise healthy, Spanish-speaking migrant worker who presented to the ER after falling off a roof. He had back pain. And when we saw him, the physical exam was relatively benign, and he had a CT scan, and it turned out that he was very lucky and nothing serious had happened. So he was discharged and given a prescription. And during this visit, we saw him twice with an interpreter, once during the interview and once afterwards during his discharge. But his entire stay in the ER took about 8 hours, and when I went back to tally it up, we had spent about 30 minutes with him. And that represents 7.5 hours of time that could have been spent better. His trip to the ER was much more complicated than what I just described. He went through triage, wait time. He went to a room where he was examined, he had a CT scan, he was discharged, he was given a prescription, and he had a follow-up appointment scheduled. All of that seems second nature to us in healthcare, but to him, I'm sure he had questions, and I don't think he was able to ask. How does he do this without insurance? How long is the wait going to be? Where are the bathrooms? What is a CT scan anyway? Is his parking going to be validated? Where's the Walgreens he's supposed to get his prescription filled at? And when is his follow-up appointment? These all lead to unknowns, and unknowns in the patient setting lead to patient dissatisfaction, poor clinical outcomes, increased expense, and these unknowns lead to patient inequities.
Let's zoom out and explore the inequities found in the ER. 130 million Americans visit the ER every year. Though we imagine the ER to be a frantic environment, 80% of those who visit are lower acuity individuals who often have to wait more than 2 hours to receive care. The ER also serves the most marginalized members of our society: Medicaid, Medicare, uninsured, Spanish-speaking individuals. The Spanish-speaking individuals themselves are the ones who often have the poorer health outcomes because they have lower functional health literacy. Physicians provide less procedures and tests and medications, and they often leave the hospital dissatisfied. Keeping all of this in mind, we decided to create Navigator, an all-in-one mobile application that aims to simplify the ER process and better help the patients navigate the complex healthcare landscape and improve the health literacy. Navigator provides engaging content, process timelines, and resource maps for patients and their caregivers. The Spanish version of Navigator is an invaluable addition to the ER experience. It actually aims to reduce the functional health literacy gap that currently exists.
Now let's imagine how different Mr. G's experience would have been had he used and downloaded Navigator. As soon as Mr. G walks in, he heads to the registration desk where he is informed about Navigator and receives a text message on his phone to download and use the app. Upon downloading the app, the first screen that he sees is language preference. He selects Spanish, and now his healthcare journey can begin. Navigator was created to inform patients about the most common steps that occur in the ED, which are currently only known by healthcare professionals. In this case, Mr. G sees his first question: have you been seen by a triage nurse? This question periodically shows up on the screen to encourage him to answer the question and keep on track with the process timeline. Mr. G has not been seen by a triage nurse, so he selects no. Upon selecting no, a navigation tool opens up and directs the patient to the nurse triage station. In addition, he is informed about any upcoming tests or procedures that the nurse may perform, such as blood draws or EKGs. This is really important because it decreases the fear of the unknown, which is a major source of stress for patients in the ED. In addition, during the course of his healthcare journey, Mr. G finds out that he has to get a CT scan, but he doesn't know what that is. On the test and imaging page on Navigator, he can click on the CT scan button and get a brief and simple explanation about what a CT scan is. This is important because we're trying to decrease the knowledge gap and promote health literacy, which is really important for patients to make informed decisions about their healthcare. By the end of his healthcare journey, Mr. G clicks on the hospital map, and this directs him to the parking lot as well as to the local pharmacy where he can pick up medications. We want Navigator to facilitate discharge and post-discharge planning. We also want to encourage patients to enroll in health insurance, as well as give them access to important documents, such as a Bill of Rights. Finally, after interviewing over 46 patients in the ER, we realized there was a need to alleviate stress and promote distraction in an otherwise stressful and uncomfortable environment. In the future, we plan to partner with local cable providers and Khan Academy to produce engaging and informative content for patients and caregivers.
Given that current patient engagement and education is not readily integrated into ER settings across the country, we felt that there was a dying need to bring in ER-specific tools to improve patient outcomes and experience, decrease burden on physicians and nurses, and lead to cost savings. Based on our direct experience working in the ER, we developed this app as medical students. We talked to patients, we talked to physicians, and we developed the skeleton for Navigator. Given that 70% of Americans have smartphones, the mobile application is a perfect vehicle for engaging patients during their ER visit. There's also the potential for connecting with electronic medical records, which are prevalent in our healthcare system.
So when developing our business model, we keep as a priority the fact that we're trying to address healthcare inequities. And to that end, we don't plan on this making a profit during the first several years. We want to put all of our resources into developing content and engaging patients. We're also aware that developing a sustainable and scalable model is important moving forward, and that's where grants like this become so important to us. We've also identified other revenue streams, such as patient engagement funds from hospitals. So many large healthcare systems will set aside up to millions of dollars to engage their patients and make them more satisfied with their stay and more likely to come back. Moving forward, we also see using a subscription model in which the emergency room itself will be responsible for paying for the app download. So we think, using our analysis, that we can charge about $1 per download here. The healthcare ecosystem is also incredibly complex, and we think that enlisting other stakeholders, such as insurance providers, hospitals, and electronic medical record providers, is an important step in getting everybody on the same page. As medical students and scientists, we think it's important to show that this has an impact, that our intervention has value. And so we want to engage in rigorous study to do that. And we plan to use the survey instruments that have already been developed and validated, integrate them into the app itself, and produce publication quality data that shows that interventions have a value in this context. And we think that we can show improvement in patient engagement scores with that. So moving forward, we are planning to, over the summer, build a bootstrap version of the app on the web. And this is where YEI and the Aetna Foundation are so important and so essential. So in the fall, we plan to deploy this website into the emergency room at Yale New Haven Hospital. And in discussions with our physician mentors, they have confirmed that we will be able to reach the 100,000 patients who come through Yale's emergency room every year. Over the winter, we plan to flesh out the app form that will be available on iOS and Android, and we will be forming partnerships at the same time. So we'll be working with those other members of this landscape to develop relationships that we can use going forward, such as Epic. We'll launch the app to other healthcare systems in the spring of 2018, and we also consider future steps. So for example, we're consider a Navigate OR app that might be used in perioperative care to alleviate some of these unknowns.
Navigator was created by Anusha Raja, Aishwarya Raja, and Dan Shaw, medical students at Yale and Mount Sinai. We brought the clinical expertise and the network connections to the healthcare ecosystem. We also received the support of ER physicians who will remain as advisors during the development of our app. And finally, with the support of Aetna Foundation as well as YEI, we are confident that Navigator will simplify the ER process and improve the healthcare experience that patients like Mr. G will have in the future. Thank you.